Hello everyone, today we're going to present a tough case in aorta hub. We're discussing a 55-year-old female patient with several cardiovascular risks: arterial hypertension, dyslipidemia, smoking, type 2 diabetes that doesn't require insulin, and a family cardiovascular history of her father who died suddenly at the age of 43, and no definitive diagnosis could be made regarding the cause of death. She has no cardiovascular disease history except arterial hypertension. She is currently on carvedilol, 12.5 milligrams, telmisartan, 40 milligrams, plus rosuvastatin, 20 milligrams. At 45 years old, she was diagnosed with a solitary pulmonary nodule, which was 10 years prior to this case presentation, and a lung biopsy was performed to determine the nature of the nodule. What they found was adenitis and associated fibrosis. Therefore, it was not neoplastic, but rather an inflammatory reaction associated with adenitis. Additionally, the patient has been diagnosed with retroperitoneal fibrosis and is on tamoxifen treatment. What is the current illness? Well, the patient comes to the emergency department with precordial pain. The precordial pain is somewhat atypical. She also relates it to some position changes. Although she says it starts in the precordium and radiates to the back, it has been ongoing for about 6 hours when she finally consults the emergency service, and it is also associated with lower back pain, and due to the pain, she experiences a presyncope. She feels like she is about to faint, which seems vagal and secondary to the intense pain for which she is consulting. During the physical exam, she was oriented and had no neurological signs. In the cardiovascular exam, she had jugular engorgement of 1/3 with inspiratory collapse, normal heart sounds. There were no murmurs in the different areas or in the back, and there was also no friction. This is something we should check, considering the chest pain if the patient might have pericarditis. Peripheral pulses were present and symmetrical, and there were no murmurs in the lower limbs. There was good bilateral air entry during the respiratory exam with no additional sounds. Bilateral dry crackles were present, and the abdomen was soft without pain with positive sounds. The admission electrocardiogram showed a sinus rhythm. Note that the sinus rhythm was around 60 beats per minute, with preserved atrioventricular conduction, a narrow QRS with good progression of precordial leads, and no STT changes. We can say it's quite a normal ECG. This was the frontal chest X-ray and the lateral chest X-ray, in which we can see a thickening at the level of the right pulmonary hilum. And note that this is related to her history of pulmonary adenitis concerning the hilum. The other findings seem normal. The aorta does not appear enlarged, and neither does the cardiac silhouette. No signs of pericardial or pleural fluid are evident. Blood test shows no major issues, with normal sodium and potassium, a normal liver panel, and normal amylases. This did not indicate abdominococcyl. CPK was normal and ultrasensitive troponin was negative. With these results, and a negative troponin makes us less worried, suggesting the patient was unlikely to have acute coronary syndrome. She has risk factors for obstructive coronary disease, a negative ultrasensitive troponin, an ECG without changes, and the pain was relatively atypical. So this moves us away from an acute coronary syndrome, but as this patient has a family history of sudden death, we started to consider that the patient might have an acute aortic syndrome because she described the pain radiating to her back, and it was a pain that caused presyncope. This is quite alarming because such symptoms were not typical for other pain types, and she also had lower back pain, which may suggest aortic extension. So, there were various signs that suggest an acute aortic syndrome. Bedside echocardiogram was performed, and some images were taken before performing the CT scan. what we should actually do as a first-line study when we suspect an acute aortic syndrome is a CT angiography of the thoracic and abdominal aorta, of course EKG synchronized to avoid motion artifacts from the heart. In this case, we will look at the quick images taken in the long axis for external use in the echocardiogram, and notice, to our surprise, that the patient presented an aortic dilation. Notice that in the measurements on the right, the aorta measures 50 millimeters, and observe the wall thickening of the aorta, both in the anterior wall and in the posterior wall. The aortic valve is reported as having no significant valvular diseases. The aortic dilation appears to be suprasinusal with that circumferential wall thickening with intact intimal layer. There appears to be no dissection flap. And the maximum diameter is 34, and the luminal diameter is 50, marking a luminal diameter of 34. The wall thickness is approximately 8 or 9 millimeters, and there is also a semilunar thickening at the level of the aortic arch. So the patient undergoes a CT angiography of the thoracic and abdominal aorta. Now we are seeing the scan from the CT in which we can see the preserved supraaortic vessels. We will see if the aortic arch shows up. Notice that the vessels are normal and show no signs of dissection or hematoma. As we get closer to the arch, this semilunar image starts to appear regarding the proximal arch. But notice that this image fades in the rest of the arch. In the distal ascending aorta, which is what we are seeing here, it also does not appear, and only now does a circumferential image start to show, as you can see here, surrounding the aorta at the proximal ascending level. If we measure this aorta, it will show over 50 millimeters. Just look. The halo scene. If we look at the sequence without contrast, we can see that there is actually no hyperdensity in the areas where the aorta has thickened walls, absence of hyperdensity, which suggests fresh blood in the wall, such as in an intramural hematoma. And if we look at the other reconstructed images, notice that at the level of the sinus portion, there is nothing. At the suprasinusal portion, where the coronary arteries come out, that circumferential thickening starts. Then we have that semilunar shape in the arch, and the measurement is approximately 51 millimeters. Notice how in the arch, the most noticeable aspect is the patchy thickening of the wall. And we also observe this hilar thickening, which could be adenopathic on the right side, which seems to be related to exactly the same image we saw in the chest X-ray. We asked the patient for a prior chest CT that she had in her studies of the pulmonary nodule, and look, this is the previous CT. The upper and lower are the same. Notice that the patient practically has the same condition, which means we are managing a chronic process where we do not see signs of active inflammation in the CT scan. Actually, we do not see signs of active bleeding, which seems odd for an intramural hematoma since it is also patchy. An intramural hematoma is often continuous in the aorta, but this appears patchy. And in the right images, we observe the retroperitoneal fibrosis present in the patient with periarterial involvement. So, the two differential diagnoses are the hematoma and inflammatory aortic disease, which may be an inflammatory aortic aneurysm, similar to what is observed in the retroperitoneal area with fibrosis. When we consider these diagnoses, we perform an MRI, which also does not show edema, but does indicate that circumferential thickening of the wall and that semilunar shape at the arch in the different sequences, and practically the same measurements. And we decided to perform a PET scan because it would show current metabolic activity, which was acute in the inflammatory disease, or rather, it was active because the inflammatory process is mostly chronic but active. And if you assess the PET, you will see that in the same locations, both in the ascending aorta and in the arch, the patient shows uptake of glucose. Thus, notice that the value we get is 9 SV, which represents active inflammation of the wall of that aorta, and the same applies at the retroperitoneum, where there is retroperitoneal fibrosis. This is what the report tells us, and therefore we see that we are managing an inflammatory process, an inflammatory aortic aneurysm likely connected to the retroperitoneal fibrosis in our patient, a disease that is chronic. If we examine inflammatory aortic aneurysms, it started being recognized as a condition in it can be observed over time, and in 2008, Kazushima published the first series of 10 cases, categorizing them into those related to aortic disease from IgG4 and those not associated with aortic disease from IgG. All these patients show macroscopic and microscopic changes and complications, with rupture being the most feared along with others, which are crucial due to comorbidities in superior vena cava syndrome because of the extent of fibrosis in the mediastinum and ureteral obstruction from the extent of fibrosis in the retroperitoneum. Little is known about the natural history of this disease, and it might be related to other fibrotic conditions, which produce chronic periaortitis and inflammatory thickening of the adventitia, and sometimes it is classified under the group of sclerosis related to IgG4. It is important to note that the key point of this slide is to observe the preoperative diagnosis that patients had when they actually had inflammatory aortic aneurysms. Pay attention that the majority of diagnoses were intramural hematomas, meaning these patients would have undergone surgery incorrectly, they entered the operating room incorrectly due to suspicion of an acute intramural hematoma, when what the patient actually had was inflammation of the aortic wall. It is significant that 75% of these patients have chest pain, and of those, 67% have ongoing pain. To diagnose an inflammatory aortic aneurysm, clinical suspicion, elevated inflammatory markers, and consideration of other fibrosis are essential, as in the case of our patient with retroperitoneal fibrosis. Certainly, multi-detector CT images are the gold standard for diagnosis. It is essential to always rule out inflammatory aneurysm when suspecting acute aortic syndrome. It is important to keep in mind the differences between inflammatory aortic aneurysm and intramural hematoma for differential diagnosis. Inflammatory aortic aneurysms have more chronic pain affecting the receptors in the 3 aortic layers. In contrast, the intramural hematoma is solely a process of the media affecting the receptors in the media, which are involved in generating pain. Inflammatory aneurysms impact the adventitia and are much more frequent in the abdominal aorta than in the thoracic aorta. In contrast, the intramural hematoma affects the media and is more common in the descending thoracic aorta. In inflammatory cases, surrounding structures are compromised, while in intramural hematomas, they are not involved. In non-contrast CT scans, inflammatory aneurysms usually present a hypodense mass attached to the aorta that corresponds to all that fibrosis, mediastinal or retroperitoneal if are present. In contrast, in intramural hematomas on non-contrast CT, you simply see the thickening of the wall with hyperdensity indicating active bleeding of the wall. In the angiotomography sequence, observe that inflammatory aneurysms show thickened walls in the arterial phase and are hypodense, like in the intramural hematoma, but in the venous phase, the wall can become hyperdense due to all that blood supply and inflammation of the adventitia, which is not the case in intramural hematomas. Well, PT scans are also included to aid in the differential diagnosis of one pathology from another. Of course, other differential diagnoses could be Takayasu arteritis, which mainly affects the ascending aorta, the arch where the neck vessels begin, infiltrating the adventitia and possibly affecting the neck vessels. It affects all 3 layers and usually causes stenosis of the vessels, while aneurysms are rare. So, what is the treatment for inflammatory aortic aneurysm? There may be surgical techniques in some cases, but it is typically managed with immunosuppressants, corticosteroids, or immunomodulators, which will stabilize the patient's inflammatory process. We need to be careful with this because if we operate a patient with this condition inflamed, the postoperative period can be more difficult. Well, I thank you all for participating in this case. I hope it has been helpful for your daily clinical practice.